This conference will now be
Uh,
recorded.
okay. Thank you, lady, for telling me that it will be recorded. So, as Daphne said, I'm Dimitri. I am.
Could I just remind everybody
Ooh,
to
there's something in
keep
the
their
background.
microphones on mute?
Thank you. That's great. So I'm one of the consultants that works in the reproductive medicine unit at UCLH, and I've had the opportunity. I am a subspecialist in fertility, but in my training, I've had the opportunity to work with various people that have been seminal in how endometriosis is managed and how we understand its impact on fertility. So I have a special interest in the nexus that happens between endometriosis, adenomyosis, and fertility. And I'm going to give you a little bit of background and hopefully some useful information about the science of how we understand this topic. My talk is fairly, yes, endometriosis, that's how I try to understand the world, but of course, I will take questions afterwards and we can discuss any particular issues further. So just a series of questions, really. The first question is, does endometriosis impact fertility? And I think you have to be, even starting from this point, you have to be a little bit nuanced because yes, endometriosis does impact fertility. So if you take the general population and you look at the chance of trying to get pregnant, what is the chance of a couple gets pregnant after a year of trying, and then what is the chance of that after a year? You see that in a general population where there's no endometriosis, the chance is reasonable, as a 25% chance of every month of falling pregnant. But in a population of couples where endometriosis exists, that chance every month is lower, but it's not zero. And remember, this is also couples that may have come to the attention of doctors with endometriosis, and there's potentially people out there with endometriosis that never know and fall pregnant. And we certainly have seen in our clinics people that find out they have endometriosis after pregnancy. So endometriosis is not by definition something that affects fertility, but in a population, the chance of having endometriosis makes it less likely that the woman becomes pregnant. So this is interesting data from Bristol from the 80s, where they would do a laparoscopy as part of their initial investigation of endometriosis. And at that time, they didn't have much in the way of treatment. So if they identified mild endometriosis versus nothing seen, you see that after 2 to 3 years trying, those that had some endometriosis identified had a lesser chance of live birth. Again, though, it's not, endometriosis is not a definite cause or an absolute cause of infertility. And why could it be that endometriosis affects the chance of conception? Well, unfortunately, endometriosis works in many different ways to affect the woman's chance. Of course, some of you might know that endometriosis refers to the placement of abnormal endometrial tissue inside the cavity of the tummy. So that maybe suggests that already the type of endometrium that some women have that have endometriosis is not quite normal, so to speak, and therefore may be less able or less likely to support implantation of a pregnancy. Then when endometriosis happens, that changes the environment inside the abdomen. And those that conceive spontaneously conceive in the space between the ovary and the tube, and then the tube collects that fertilized egg and helps it travel down into the womb. If the environment there is being altered by the endometriosis through inflammation, then that interaction doesn't happen. It's known that the tube may not work as it should do, and even the sperm, the ability of the sperm to change and become able to fertilize the egg may not be as good as it would otherwise have been. And of course, some will have an endometriosis that affects the ovary directly, and then the function of the ovary may be affected through that. So endometriosis is one of those things that is very, very variable goes from one spot and minimal to severe, and the way it impacts things is also variable. So it is important, before you treat anyone that has endometriosis, and this may not be treating for fertility, may be treating for consideration of pain, to understand what the woman's fertility desires are. Age, of course, will be known, but at any age, ovarian reserve will be variable, and I would strongly encourage everyone to know their ovarian reserve before they embark on any type of treatment for endometriosis. 25% chance to identify and clearly define the type and extent of endometriosis a woman has. Because, as I said, it goes from very limited, just a spot, to an endometrioma in one of the ovaries, to anatomical problems like a blocked and swollen tube, or more severe deep endometriosis that affects the bowel, the bladder, being pregnant, distorted the anatomy. So the way I'm going to try and break it down so that we can have some understanding of this is break it down into mild and more severe disease, look at ovarian cysts, endometriomas, look at hydrosalpinges, and then think about the adenomyosis. Because in my experience, a label of endometriosis covers a very wide spectrum of disease, and these stages of endometriosis will have different surgical and fertility approaches. So starting from stage 1 or 2 endometriosis, here we're talking about endometriosis that may not necessarily be seen on a scan because it is so mild, but could be contributing to pain and could be contributing to difficulty with conception. So should we be offering surgery as a treatment for a woman who's hoping to conceive if we've identified that she has mild disease? This is one of the things that we have some good evidence about. And I'm very excited about it because it's rare in the field that we have good evidence about a surgical treatment. And the randomized controlled trials, so some women having surgery, all of these women having surgery, but some having treatment and some having just observation, showed that those that had some treatment of the mild endometriosis, meaning excision removal, had a better chance of conception in the immediate 6 months afterwards. And I want to stress here that sometimes I come across couples, women that have had a laparoscopy and then been advised to have some sort of adjuvant treatment, maybe go on the pill, maybe have a Cerazette, maybe even have GnRH analogs right after the surgery to keep the disease under control. I think that is not the right approach. If you're going to have a laparoscopy to treat endometriosis for fertility, then the optimum time to try would be directly after the surgery. So yes, surgical treatment for mild disease is an option, but it's not a very effective option. So if you look at the difference between the groups that had invasive treatment versus just observation, there was an 8% difference in late pregnancy, meaning a pregnancy that goes on into the second trimester after 6 months. So this is a good option for a younger woman who has mild disease and has some time, but may not be such a great option for someone who's a bit older and time is not on their side. Now, moving on from mild disease, stage 1, 2, some women will have endometriosis that affects their ovaries. And then the question is, should we remove an ovarian cyst, an endometrioma, not for purposes of helping with pain and discomfort, but for the purpose of improving the chance of conception? And here the evidence, and we certainly have all these studies that are listed here, but and they show that if you do surgery with an ovarian cystectomy, the chance of pregnancy may be up to 50% afterwards. But you see that there's no control. There's no control of women that didn't have the surgery. And also, this data here does not distinguish between spontaneous conception and IVF. Therefore, it's difficult to infer from this information whether it's the cystectomy or whether it was the IVF that led to the pregnancy. And moreover, whenever you look at scientific data, you have to think about publication bias. So people are more likely to publish a study that has a positive result rather than a study that shows that the treatment didn't work out. If one is having surgery for an endometriotic cyst for pain and also wants to take the benefit of fertility, then the approach to removing the cyst should be excision rather than burning it off, which is what we call coagulation. Because, again, people have randomized women to one option or another, and doing an excision, actually removing the cyst wall, seems to give a better chance of pregnancy versus just burning off the endometriotic tissue. But before going and doing an operation in a woman's ovary, we must always know and discuss with the couple and the woman that operating on an ovary for removing an endometrioma has an impact. And that's because the endometrioma is in a population. Technically, it doesn't have a capsule, it has a pseudocapsule. So by definition, when you remove an endometriotic cyst, you end up removing a little bit of normal ovarian tissue. So if you look at this analysis of histological specimen, 80% contained ovarian tissue, which is what you'd expect because of the way that endometriotic cysts develop. But that means that if you're going to remove an endometriotic cyst, you are going to you are going to reduce the woman's ovarian reserve. So in studies where women had their ovarian reserve determined before the surgery and after, you see that the amount of AMH, which is a standard marker of ovarian reserve, has gone down. So is that important? Well, in the context of fertility, ovarian reserve plays a role. It plays a role when a woman wants to have her eggs collected, embryos made in the lab, and an embryo transfer. The better the ovarian reserve, the more eggs will be collected through an IVF cycle, the more embryos will be available, and ultimately the more chance the couple will have, or the single woman will have, to have a pregnancy. And therefore, if you reduce the ovarian reserve, you are potentially making the woman more likely to need more than one cycle. Okay, you might say, well, I will accept that because removing an endometriotic cyst will improve the outcome of the IVF cycle. But actually, the evidence doesn't support that. There has been a randomized trial again where people did the operation in some and didn't do it in others. And in those that had the operation, there was less eggs collected, there were less embryos available, but there was no difference in terms of pregnancy and ongoing pregnancy. So if you put that in a systematic review, which is the highest level of evidence that we have, you see that it doesn't support doing that. So where does that leave us? Well, it leaves us in a place of nuance. You have to look at all the variables that come for the woman and then make a plan based on that. If the woman has a good ovarian reserve, she's younger, there's not been a previous operation for her endometriotic cysts, she has pain that is making life very difficult, there's only one-sided cyst, then you might think this is the right person to operate on because she is suffering, and yes, the ovarian reserve will be reduced a little bit, but that won't matter in the fullness of time. If the woman has had previous operation, there's cysts on both sides, the ovarian reserve is already reduced, then pregnancy, then you may think, actually, this is a woman where it would be better to go for IVF first. Now, moving on from endometriotic cysts, let us consider rectovaginal disease. So now we're talking about endometriosis that is not superficial, but it's deeper down in the pelvis, in the space behind the womb and the bowel, sometimes in the bladder, and implants more deeply, what some people call deep endometriosis. And this is one of those difficult debates in the field of reproductive medicine, because the evidence is very unclear. One of the better studies that I have seen is this one from Italy, where basically they didn't randomize women to an option of treating the rectovaginal disease or not, but it's more of a, these are your options. You can either have surgery or you can have a expectant management and continue trying. And you see that in this non-randomized trial, in the 24 months, there was no difference between those that had surgery and those that didn't in the chance of becoming pregnant. So based on this, I don't think you would offer a woman an operation that some of you might know carries significant risk of, say, bowel injury or a colostomy, or needing ureteric stents, needing prolonged time in hospital for the purpose to improve fertility. If you do it for treating pain, then you can say that at least it's not going to negatively affect the chance of conception. The reason I say this is a fairly difficult field is because other evidence is out there to say that it actually makes a difference. So if you look at the group that's S here, you see that the one that's S had higher chance of pregnancy, but you really need to be cautious, because in this study, those that had expectant management, or more than half stopped trying, presumably because of pain, of course, versus only 25% in the surgical group. So rectovaginal disease requires a really nuanced conversation as to how to best tackle it in the context of fertility. Hydrosalpinges, so a technical term for tubes that have become blocked and swollen. You might know that tubes continuously produce fluid, and if you end up blocking one side of them, then they become swollen, sometimes through a pelvic infection, sometimes through endometriosis. And it is clear that if you have a hydrosalpinge that you've seen on ultrasound scan, then the right approach is to remove it before you do an embryo transfer. I think from that, it also makes sense that if you're hoping for spontaneous conception and one of the tubes is a hydrosalpinge and the other is normal, it probably makes sense to remove the hydrosalpinge, the injured tube, because the same mechanism that makes IVF less likely to work probably means that spontaneous conception is also less likely to work. There's two mechanisms. One is that the fluid in a swollen tube seeps into the womb and affects the embryo, it's embryotoxic. And the other is that that fluid changes the endometrium and stops it being receptive for implantation. So I make an assumption that that mechanism would apply both for spontaneous and assisted conception. A word of caution here, the evidence is clear that it has to be a hydrosalpinge that is visible on ultrasound, and not one that is just seen on surgery, because this may be different. There may be different species. Okay, so another question is, okay, well, is there any information that can be gained from surgery to be able to say that this couple now, after we've done the operation and we've treated the endometriosis surgically, is likely to fall pregnant and therefore we can let them try? Or now we've done the operation, we've treated the endometriosis, but this couple is less likely, so we may think you ought to think of assisted conception. So if you look at this, is a very interesting study, I think from the States, somebody who's developed an endometriosis fertility index for surgery. So they take a number of variables, including the woman's age, previous history, and the findings at the time of surgery. And based on this, they then say, okay, if your endometriosis fertility index score is 9 to 10, then your chance of conception in the next period of time is up to 80%. If your score is 0 to 3, then your chance is down here, and think about assisted conception. So moving on from endometriosis to adenomyosis, just by way of definition now. So adenomyosis is when the lining of the womb, the endometrium, implants into the muscle of the womb, which also contributes to painful periods. There's always been a question as to whether it makes any difference for pregnancy. And there's 4 papers here. Without going into too much of the detail, 2 of these 4 say yes, it makes a difference. So this one here, 44% in the control, 23% in the adenomyosis group. These 2 didn't find a difference. Now, we spent some time thinking about this and wondered why could it be that some identify a difference and some don't. And probably the reason is that not all adenomyosis is equal. In the same way that endometriosis is variable, and some women have a stage 1 superficial endometriosis, some women have a stage 4 deep severe endometriosis. Same thing with adenomyosis. Some women have mild, this one on the left, some women have more severe disease. And so then it could be that if you study only women that have mild disease, you don't find any difference. If you study those that have more severe disease, you do. And this is essentially what we showed in a paper published a couple of years ago now, in collaboration between UCLH and Guy's and Thomas. We recruited somewhere close to 400 couples going through IVF and found that those that had a more severe adenomyosis were less likely to be successful after IVF. If they had a milder form of the disease, the chance wasn't that badly affected. You could say that it's almost normal here. So the question that often arises is, if there is adenomyosis, what do we do about it? It is in the fabric of the womb, so it's a very difficult thing to get rid of. There's surgery that has been suggested, but I think most people consider that experimental at this stage. And there's an alternative approach, which is to make the period before ovarian stimulation longer, deprive the adenomyosis of the hormones that maybe fuel it, and therefore, at the time when you come to do an embryo transfer, hope that there's less of an effect of it. And this Chinese paper is a retrospective study that showed that this approach might work. And just if you look here, they said, okay, this is downregulation longer, 49%. This is standard downregulation, 21%. Now we have a few doubts about this data, and we're doing our own study. And so hopefully that will start recruiting some point this year. Another question that Rosie shared with me that came up in discussion is, well, okay, now I've been diagnosed with adenomyosis, endometriosis, I have become pregnant, and I'm worried about what that means for my pregnancy. And there's a very helpful paper that was published last year, looked at some women have studies that have asked this question. And you see that for quite a few of these, for example, gestational diabetes, it doesn't seem to be that changes the risk. But there are some things that seem to be more likely if conception has happened in the background of endometriosis, irrespective of how the conception happens. So if natural conception or IVF, ICSI, or combination of natural and ART seems to be associated with a higher risk of preterm delivery, cesarean section, placenta previa, low implantation, abruption, and scarier things like intrauterine death, neonatal admission. Again, I would urge a little bit of caution with this data because a lot of it is retrospective, meaning this is including women that we know had endometriosis adenomyosis. And therefore, there might be a whole bunch of women that had completely normal outcome that we didn't study and seem to detect an artificially poor outcome when actually things are not that bad. This one we can skip. So just to summarize, I try and sort of simplify as much as one can just to make it easier to make some choices. So you can look at a graph where you get severity of endometriosis on one axis and ovarian reserve on the other. If ovarian reserve is good and endometriosis is not that bad, surgery is a good option. And then the couple can try and conceive spontaneously and avoid the palaver that is IVF. If ovarian reserve is not very good, then I think IVF is the first option because surgery might make assisted conception in the future less likely. If ovarian reserve is good, but endometriosis is severe, I think that's the group where I haven't come up with an answer that is very good. I think it is very much tailored to the individual and what exactly endometriosis they have. A good source of information is this guideline produced by one of my colleagues, he was part of the steering group, Mr. Saridogan. This is the European Society of Human Reproduction and Embryology information for women with endometriosis hoping to conceive. Well, across the board, but it has a good section of fertility as well. And this is as good as you can get it in terms of scientific validity. And I would urge you to have a look at this. It's available online, of course. And I will leave it at that.